Welcome, everyone. My name is Marie Engh, and I would like to speak about my PhD. Exactly. And I would like to speak about my PhD thesis about tissue acquisition in solid pancreatic masses. My vision is that improved diagnostics of pancreatic cancer can lead to improved outcomes for the patients. And to aid in this, my mission is to contribute to clearer guidelines for more efficient sampling of pancreatic cancer. I have 3 projects, one of which I'm calling my 0th project, since I started it a long time ago, and I will first briefly introduce it to you. My first project, or my 0th project, is about the proportion of acute pancreatitis patients affected by gastrointestinal bleeding. We're dealing with a condition of gastrointestinal bleeding in a context of acute pancreatitis in a population of patients. The clinical implication is to clarify to clinicians if they should expect gastrointestinal bleeding in their patients. Just quickly, our outcomes, we found a rate of 4% overall and a rate of 16% in severe acute pancreatitis. Now for my first real project is a comparison of diagnostic adequacy of needle tips in endoscopic ultrasound-guided tissue acquisition of solid pancreatic masses. Endoscopic ultrasound-guided tissue acquisition is a common diagnostic method in gastroenterology. 10% of samples, approximately, are inadequate for analysis. This leads to the need for resampling, which carries a risk of adverse effects, the need for sedation, and costs of around $2,000 per patient. There are 5 available needle designs for tissue acquisition of pancreatic masses. And the only thing in the guidelines is that the 19-gauge fine needle aspiration needle, so the Menghini needle, or the 19-gauge fine needle biopsy needles are suggested to get a core tissue specimen, as well as 22-gauge FNB needles. However, the evidence is low and the recommendation is weak. So my aim is to compare the diagnostic yield and adequacy of all the needles used in endoscopic ultrasound-guided tissue acquisition. I'm dealing with a population of patients undergoing endoscopic ultrasound-guided tissue acquisition for a solid pancreatic mass. The intervention and comparison are any FNA or FNB needle, and the outcome are diagnostic adequacy, specimen yield, number of passes, adverse events, and technical failures. I hypothesize that there is a superior needle among the needle types in terms of diagnostic adequacy and specimen yield. We performed our search on October 15th, 2021, and we ended up with 78 full texts to extract data from. For our first outcome, which is the histological adequacy, that is a sample that is adequate for histology to diagnose the mass, we found this network. Each node represents one needle of one size, and the size of the node indicates how many studies we're dealing with a specific needle. The connection between the nodes show how many studies and how many patients were for each comparison. We managed to create this ranking where you can see that for histological adequacy, the best needles are the fork tip needles of any size, along with the Francine needles. The absolutely least effective were the Menghini needles of any size. I just wanted to show you this net league table. I've color-coded it. Green means better, red means worse, and the bold colors mean statistically significant. There are none. We managed to have, the orange here are the direct comparisons, and the blue are indirect comparisons based on the direct comparisons. So we managed to create quite a few comparisons from the about 1/3 direct comparisons that we had. But unfortunately, as mentioned, nothing was statistically significant. We have the second outcome, which is cytological adequacy. Samples good for cytology. The network is much smaller. It's dealing mostly with the 22-gauge needles, but we managed to get one of every needle design. Here too, we have a ranking. Fork tip outperformed all the other needles, although the 25-gauge reverse bevel needle was nearly as good, and the Menghini needle is again the worst. We have this forest plot, which compares all the needles to the Menghini needle, which was the one that was in the most comparisons. And you can see that the reverse bevel needle, although not statistically significant, had a 6 times higher odds of having an adequate sample than the 22-gauge Menghini needle, which is definitely clinically significant, but underpowered. Again, net league table showing how many comparisons were actually statistically significant. None. About 1/3 of our comparisons were direct comparisons, and the rest were indirect comparisons based on those direct comparisons. We have further outcomes, technical failures. This is our network. I've already explained how it works. And in our ranking, the Francine needles were the best, and the reverse bevel were the worst of the FNB needles. Menghini, again, by far the worst. In this comparison, we actually had some statistically significant results. The reverse bevel needle was about 4 times as likely to have technical failures as the 22-gauge Menghini. The 19G Menghini was the worst. We also have adverse effects with this network. In the ranking here, the reverse bevel was the absolute best. The Francine needle was the worst of the FNB needles. Again, just to demonstrate our proportion of direct to indirect comparisons. And a quick forest plot to show that the best needles were about twice as likely to have adverse effects than the 22-gauge Menghini, whereas the forward bevel needle and the reverse bevel were about 70% less likely to have adverse effects. Unfortunately, here, again, none of the comparisons were statistically significant. In summary, this is a network meta-analysis including more than 50 studies and thousands of patients, which is definitely a strength. It compares all the available needles for endoscopic ultrasound-guided tissue acquisition of solid pancreatic lesions in several sizes. However, due to low event rates for technical failures and adverse events and high uncertainty leading to wide credible intervals, we have no statistically significant differences due to uncertainty. In conclusion, even though nothing was statistically significant, we see that the fork-tip needles had the highest rate of adequate samples, but carried a slightly higher risk of adverse effects and technical failures. The Menghini needles performed worst on nearly all outcomes. The reverse bevel needles were good in terms of adverse effects, technical failures, and histological adequacy, but not cytological adequacy. Francine needles carried a relatively high adequacy but have the lowest rate of technical failures, but they lead to a higher rate of adverse effects. Based on this, we would like to suggest to choose fork-tip or Francine needles if adverse effects and technical failures are not of concern, to use a 22-gauge or 25-gauge fork-tip to acquire a tissue core. This is actually different from the current guidelines. And for research, we suggest conducting further RCTs to comparing several needles, to report the adverse effects clearly and define them clearly, and to report adequacy for cytology and tissue core for histology separately. My second project is also dealing with tissue acquisition of solid pancreatic masses. This is done using endoscopic ultrasound, and endoscopic ultrasound can use different types of ultrasound. We would like to look at the difference between conventional and contrast-enhanced ultrasound, which, on the one hand, contrast-enhanced ultrasound increases the visibility. However, it decreases the time window during which sampling can be performed. So based on this, we would like to investigate whether contrast-enhanced ultrasound may increase the sampling adequacy because there are arguments for and against. We're dealing with a population of patients undergoing endoscopic ultrasound-guided tissue acquisition for a solid pancreatic mass. The intervention is contrast-enhanced endoscopic ultrasound, and we're comparing it to conventional endoscopic ultrasound. And the outcomes are diagnostic adequacy, specimen yield, number of passes, and adverse events. Our hypothesis is that contrast-enhanced endoscopic ultrasound is superior to conventional endoscopic ultrasound. The clinical implication would be to aid clinicians in choosing the correct technique and decreasing the risk of reintervention. To sum this up, hopefully I will resubmit my 0th paper soon, and submit my first paper by May 2022, my second by July 2022. I would like to leave you with this quote that's the starting point for most scientific research. I don't know, and I would rather not guess. Thank you for your attention. If there are any questions or comments, I welcome them now.
You were talking about histological adequacy and cytological adequacy. Why both are important? I mean, if we have the diagnosis from the histology, why is it important to have a good cytological adequacy?
In this case, I would actually say cytology is more of a backup. I mean, I included cytology because I'm also including fine needle aspiration needles. So those are usually good for the cytology, not so much for the histology. obviously, if you have if you can diagnose either with the histology core or with the cytology, you're fine, clearly.
22 and 25 gauge needles are good for core. And I was surprised because I thought the sizes matter. And the 19 gauge is the thicker needle.
Yes.
And I'm surprised why the thinner needle, the 25 gauge needle, is good for core.
To be honest, this is surprising to me as well, and this is clearly different than the current guidelines. So this is just what happened to show up in our results. I think that's a novel result.
Do you also found out what is the price of these different types of needles?
Well, I haven't investigated the cost. However, obviously the new needles are more expensive than the Menghini, for example, or the older type, the Westcotts. But this price difference is not expected to stay that way. I mean, the needles are only more expensive as long as they're new, they're cheap to produce, and as soon as the patent will lapse, they will become essentially the same price, in my opinion.
What was the time range of your literature search? Because I could see some needles which seldom used nowadays.
We did not set any limitations for the time. We just searched until October 2021.
Okay.
Did the adverse events include tumor spread? I think because that could be an interesting question as well.
Most studies did not report the exact definition of adverse events. However, since none of them had follow-up, no.